Matt Miner, CPA, is the Chief Financial Officer of Columbia County Health System in Dayton, Washington, an independent rural health system that includes a critical access hospital, assisted living facility, 2 rural health clinics, and a freestanding clinic. He began his career in public accounting, where he earned his CPA license and developed expertise in Medicare and Medicaid reporting, grant compliance, and financial reporting for Washington State public hospital districts. We also have Jeff Weber, is a healthcare IT executive with more than 30 years of experience guiding hospitals and health systems through technology transformation. As managing director of consulting operations at Tegria, he leads teams delivering large-scale EHR implementations, IT assessments, and optimization projects that streamline clinical workflows, improve analytics, and strengthen long-term digital strategies. Turn it over to you.
Thank you.
Thank you.
So I'll get us started a little bit. So Jeff here is the subject matter expert on this, and my role in this conversation will be that of the obstinate CFO that really just wants to get this over with and doesn't want to put a lot of thought into it. So bear in mind, this is not how I feel, and please don't judge me harshly based on this character.
Please do. So first off, who's been involved in an EHR implementation in here before? A few people. Keep your hands up if this is true. Were you on time? Were you under budget? Did it meet your expectations? I didn't think there was going to be hands up. That's hard to do. It's real hard to do, and that's why we're going to talk about this and why it takes long. So we're just going to kind of use a scenario as a background. We've got a medium-sized hospital we call County Health that has a lot of things going on. They're in a 4-county region. They've got some clinics that are spread out. They got an EHR and they're live on it, but it's not meeting their expectations. Regulatory challenges are around the corner, and they really want to focus on modernization and maintaining independence. It's really important to this organization. The challenges they have ahead of them, they got an EHR contract that's possibly needs renewal. They have competition concerns, leadership concerns, don't have access to data that they want at the right exact times and things like that. And the board's seeking clarity on where they're going with AI, like we talked about earlier. They want to know if we're using that is this working? You okay? Okay. And how that's going to go. So they come back and they come up with a strategic plan, and one of them is to replace the EHR, create a data analytics team, work on clinical integration, improved revenue cycle to focus on vendor solutions that, and create more dashboards for the organization, develop an AI strategy, and then create a governance model for all of these things. So it's quite a bit for the IT department to take on by themselves, which is why they shouldn't. They should share these challenges with the rest of the organization, and we'll see how that works through. So,
but I mean, really, it's their problem, right? I mean, they need to pick a program and install it.
Well, that's correct. And in circumstances, so let's take an example. So during this implementation, because an EHR is more than just electronic health record. Usually it's an HIS system, right? It has some materials management, potentially your payroll system, your GL system. So if we just do it, you're okay how I do the chart of accounts, right? I know some sub-accounts. I'm going to change the chart of accounts during this. Are you cool with that?
No. They should do it the way I want them to, but...
Well, then I'm going to need you to be involved, right? Because I don't know what you think. I don't know what you're thinking all the time. So we're going to need your participation when we look at that chart of accounts, as well as about 1,000 other things during this project. Not all to you, but to the C-suite and to your team.
Go ahead and rest the mic, touch your chin.
Okay, sorry. All right. So this is actually a typical time frame you would see. I know there's a deadline for this EHR renewal, but we should have been ahead of that a long time ago. If you are not spending 6 months planning for these type of implementations, you're going to fail. There's going to be some kind of mistake you're going to make along the way, because you need to understand the resources you need, the time it's going to take, the relationship with whatever vendor you have, and the amount of money it's going to take to do these things. And what is the scope? The scope should be aligned with your business, which we'll see in a second, and it should meet where you're going as an organization, not where you've been. You shouldn't be trying to fix the things that you're dealing with in the past, but what are the problems you're going to be working on in the future going forward?
So at what point do I get involved?
Day one. When I first implemented my first EHR in 2006, once I realized we needed to do this, I was an IT leader back at a small 100-bed hospital. The first conversation I had was with my CFO. I took him to lunch, and I paid for it, and I said, I'm going to need X million dollars in the next 5 years to do what this organization needs moving forward. This is right before meaningful use had come out, so we actually got ahead of some of this. But that was the first conversation I had. I didn't go to the CTO. I didn't go to the CMO. I went to the CFO because I knew dollars and how we're going to pay for this was going to be a critical part of this. I didn't want them to be unprepared or not knowing where we were going to go. These are the different phases we'll kind of walk through this, but I really do think if planning is the one you need to spend the most time on and is the most important on these. And Pablo Picasso agrees with me. I mean, he says that you need to develop a plan and you need to believe in it. And that's a really important part. And a plan is not just that Gantt chart I showed you. A plan is a project charter. It's a communication plan. It's a governance plan. It's a resource mapping plan. It's all of the things that are going to help the organization see where they're going and make decisions along the way. And without that, you're going to have people making their own decisions, like me setting up the chart of accounts, or me deciding that the CDM needs to be rebuilt when that's not part of the scope. All these things can be part of the scope, but we need to define that in the planning side. We need to understand what we're doing, when we're going to do it, and how that's going to fit into this implementation.
But once we picked a vendor, I mean, they should have a plan. I should just go with that, right?
We should, much like you would buy a car and only listen to the car dealer, right? So when you select a system, whether you're selecting straight from the vendor like Meditech, Epic, or Oracle, or you're working with a partner like Providence Multicare or someone else to use their instance, you need to work on the contract as much as possible. You need to know what's in there, and it needs to, if it's not written down in the contract, it doesn't exist. So if they tell you that referrals are automated via AI, and it's not in the contract, then it doesn't exist. And when it doesn't show up, you don't have any recourse. So it's really important that when you select your vendor, you understand their contractual relationship, because this is a relationship you're going to have for a long time going forward. You're going to have ups and downs. They're going to have ups and downs. You're going to have staffing challenges. They're going to have staffing challenges. And you need to be able to work together to solve those problems. And if you don't have a good relationship or you don't have a good contractual backup, you're going to be in trouble. The other thing in contracts that you should always have is a divorce clause. About 25% of Connect projects ultimately look at breaking away from their Connect partner at some point. Many of them don't because they don't have a good divorce clause in their contract. And so there's no easy way for them to get out in the middle of a 5-year or 10-year term that they've signed up for. So this is really important things to think about. The business, not the contract and not just the EHR implementation, but how am I protecting the business going forward, with any contract. So in planning and preparation, right, we mentioned the aligning with the EHR, with the hospital's objectives. Why are we doing this? What are the key motivations for it? What are we expecting to get out of it? Those are really important things. We need to establish governance and accountability. So that's typically your C-suite or some component of it is helping to make decisions, clear obstacles, make sure we have the right resources available, solve problems where departments disagree with each other about how something should be done. We don't want every decision going to governance. We want the important ones going to governance so that they're involved in the project, they understand how it's going and where it's going to be at. The other thing is, you got to have a great budget, a clearly defined budget that tells us when we're going to spend money, how much we're going to spend, and what happens if we don't have enough money. Is there a contingency? Are we going to change scope? What happens if time changes? What if we're not going to go live on the right date? That means it's costing us more money and resources, potentially access to the system. All these things add up to total costs. And building a total cost of ownership model early in your planning so you understand what your 1 year, 2 year, 3 year, 5 year horizon is on cost is critical. And believing in that. And you have to help me with that. Because if you're not helping me with that, then I don't know the cost of the average overtime for nursing. You know, what are we going to do for backfilling? The revenue cycle director is going to be on the project, and those kind of things. And that's where I need your help, Matt.
Why do we need to backfill them? Can't they just do their job and do this at the same time?
Yeah, so they could, and much like if you were going to build a new surgery center, you could just have the maintenance department do it too. Just give them the tools, buy a tractor, right? They can start digging a hole and figure that out, but that's probably not what best use of their time. So they're not idle right now. Their job has to continue to get done, and this is the biggest problem with this when it comes to resourcing. Organizations just try to add on to other people's plates. Like you said, IT will do this, but I just showed you IT had a bunch of other things to work on. There is one really easy way to do this without making it hard for the organization. And Matt, do you have any idea what that is?
Getting some help.
We can just shut the hospital down for 5 months, and then we could build this and everybody be available and all those kind of things. But that's not an option, right? We can't do those kind of things. This is in real time. We're working on the airplane while it's flying. We're using the same people who are flying the plane to work on it. So we need to make time for them. We need to backfill, or we need to find expertise, external, to come in and do the work for us, either on the backfill side, the legacy side, or on the front side of building the new system or workflowing it, localizing it is a better term for where we're going. This jumps a little fast.
So my old system's pretty crappy. So if we get this new system in, I mean, day one I'm going to get a lot of efficiencies, right? Things are going to be good.
Probably not day one, because that's going to be a lot of change for the organization. Hopefully we've trained everybody and we've tested this out and everything's working. But as we'll see in the timeline, it's not day one when you're going to see any ROI. In fact, it may be 3 to 4 years later before you really are stabilized and you start to see normal operations with the system. And those things. So it's not going to be day one at all, Matt. I'm sorry. But we're going to plan for that, right? We're going to figure out, like, when we go live, what's cash flow going to be like? If we don't bill for 15 days, what's the impact of that? And so that's what I want to talk to you about on a regular basis, is how we're preparing for that and how we're going to manage through that. One of the examples I've seen some organizations recently do is if they're on a different ambulatory system versus an acute system, is bring one or the other up first, usually the acute system, and let the ambulatory system run for maybe 30 more days on its old technology so that you're getting bills out normally through that system and your change is on a limited side. So maybe 40% of your revenue is being affected in that first go live, and then your other 60% being ambulatory is being picked up in the second phase. And you've already gotten through a lot of the challenges at that point going forward there. So the other part of this is when you get the system, the vendor, whether they're Multicare or Epic or Meditech, they're going to say, we've got standard content in there, it's ready for you. All you're going to have to do is really test this out, make some minor changes. That's a big mistake because no hospital is the same. And localization is really important. So if you have specific workflows that are going to work for your organization, you need to make sure they work in the new system. This is often something it's too late to do after you've signed the contract, but if you have requirements for how the system is going to run, put that in the contract. Create a requirements matrix, a requirements document that you work with your departments on, and give that to the vendor and say, show me in the contract exactly how this is going to be done. And that will hold the vendor accountable at some level and at least give you an understanding of if they come back and say, well, we don't do that, that you then can plan for that and figure out what we're going to do different.
Yeah. Well, I mean, like you just pointed out, though, all my staff are busy. They're doing their jobs. So, I mean, how is this more important than them just continuing to do their jobs and we can just figure it out once we are in that point?
He's racing to my next quote. If we don't have time to do it right now, when will we have time to fix it? So choose when you're going to do it, right? If you want to fix it on the back end after we're live and after people are going crazy because we can't get clean claims out, then that's fine. Then let's build that into the budget. Let's build that into the plan and make sure that after we go live, we're optimizing immediately and we're building the system we want. Or let's try to do that during this time of the project and try to localize and build the right workflows for the project, for the implementation that we're working on. In this phase, a lot of this is what we saw earlier with the AI too. Map out workflows, know what your current state is, know what your future state is, be able to see where the system's going to change, be able to see where staff might need to change the way they're acting, and those kind of things. Configuring the EHR to match your local needs is something that your vendor may push back on, and you need to know how you're going to push back on them. Many vendors will say, this is the way our system is built, best practice. You can't change the system to do that unless you have some type of decision document or something. Well, then do that. Do a decision document. Tell the vendor you're changing it. Tell them why you're doing it, and make them support it from you. These are, again, partnerships, but they're not just whatever the vendor says goes. This is your system, it's your hospital, it's your resources. You own that part of it, and if you don't do all those things, you own the outcome too, not the vendor. And so what we see a lot of times is, we assume the vendor partner has our best interests in heart, and they've done this a lot of times. The salesperson or the mediator from the Epic Connect project comes out and says, look, we got you. We understand exactly what you want, how we're going to do this. We've done this 100 times. Just trust us. It's all going to be there. It's not. You need to be prepared to push back and understand what's not going to be in the system.
Yeah, well, surely their specialists understand hospital operations, right? The reality of running a day-to-day.
Well, that depends on your partner. If you're working directly with one of the big vendors, the term specialist is often used, and that's usually a person who comes out and may understand a particular part of the system, maybe a module or a particular type of, like the lab or the pharmacy and those kind of things. My experience is those staff members, that's all they really know. They're usually lower paid, they're entry-level folks. They've been trained for 1 or 2 years, and they're out talking about their software in your system. They're not out there talking about hospital operations and how we're going to get an authorization referral, or how surgery patients are going to move to the floor, or surgeons going to have to sign off on drugs and those kind of things as they move. That's not what they're experts in. They're experts in their software. Now, if you're working with a Connect or community work partner or something like that, you probably will get some people who have experience in operations, and that can be very helpful because they can tell you, well, I know this is the workflow you're used to. This is how we do it in our system, and this is a better workflow. Let me show it to you, and they can show you that. That's really the difference between working directly getting the software directly from the vendor or from somebody who's already built it, is they have a sandbox to show you how it works. And that can help to convince or show other people in the organization that we can change the workflow. We can change the way we do things. So again, like Matt said, if we don't have time to do it now, when are we going to have time to do it over? And this is, when it comes to testing, one of the biggest mistakes every organization makes that I've been part of is the people who do the testing are the people who are doing the building or the setup of the system. Those are the wrong people to be doing testing. The people who should be doing testing are the people who are doing their jobs today, are not part of the project, and you've given them a little bit of training, but you've said, now go do your normal job here. That's when you'll get good testing. You'll get good results. You'll understand where your gaps are at, where the problems are going to be at in the future with the system. If you use the people who are building the system during testing, often what you'll see is they'll make the fixes during testing, which then is outside of change control. We don't know what originally caused the problem. We don't know if we have the problem in other places. Fixing it in one spot in the system doesn't mean we fix it everywhere. So this is, and testing should take a lot of time, and you should not rely on the vendor only. Again, the vendor will bring what they call scripts, testing scripts to the table. Those will be things that they've used before that they know most of the time are going to work in the system. The scripts need to come from you. We need to build those for our organization, what's important to us, and how we're going to push this forward to solve the community needs we have, not what the vendors, says will make their software successful.
So my testing's not going well, but my go live date's set in stone, right? Should I just keep going forward?
Well, no. Go live is a milestone. It's not an end state, and it's not something that's locked in stone. That's, again, something back in your contract you should think about is they're going to give you a live date, a delivery date, first access date, all these kind of things you're going to see in your contract. In there, you should go ahead and ask for, what if we miss our date? Can you guarantee me another date 90 days later, 30 days later, or whatever your time frame is? Most of the vendors are going to say, oh, we don't do that. Push them again, push them again. They will do it if you push them enough on this. And you should lock in a contingency date, whether it's 90 days later or 120 days later or whatever it is. I will say a contingency date that's 30 days later is not very effective. Because if you're 30 days from go live, you're not going to have a whole lot of time in 30 days to fix the testing and make these things. If you don't go through the right stages, the right gates in testing, we're not moving forward. We're not moving to training. We're not going to train people on a system that doesn't test out and doesn't provide the value and the things we're looking for. Like I said, a custom plan. Don't rely on your vendor partner's plan. Create your own or find those. Ask ChatGPT to create you a plan. No PHI involved in that. Look at it over as it comes back. That's one of the things I would probably do. Don't forget about your external systems. This is a place that a lot of places make mistakes on testing, is they test patient enters the organization, they get their procedure or their orders, and then we drop them a bill. But what about if it's a reference lab? What if the pathology has to go out? What if we don't have some type of test here and we need somebody else to do it? Those interfaces need to be tested also, and they need to be ready. And that's another part. A lot of times, as you work with your external vendors, you've got to work with their timetables too, and that's why in the planning part, you want to put those things into the time frame.
Well, the vendor told me it would work, and I don't want to bother the external, labs with testing. So
I mean, you don't want to spend money, right? That's what
I mean.
It's everybody can trust their vendor as much as they want, and it is, to me, it is like buying a car. If you you want to buy a new truck and you go to the Ford dealership and the salesperson tells you it's great, it's going to be exactly what you need, you're probably going to buy that truck and that's going to be fine. 6 months later, it might not meet your expectation. You might realize you paid $10,000 too much, all kinds of things. And that's why you need external data. You need to look at consumer reports. You need to talk to your friends. You need to drive the car for a little. Go rent one and see if you like it and those kind of things. Don't just listen to your vendor. I'm a vendor. Don't just listen to me. Ask other people. Ask places that have done this before. That is really, if I have one thing to take away, is talk to somebody who's done this before. Let them give you lessons learned and really believe them. Don't say, well, that's because they're small. That's because they didn't know what they're doing. We do know what we're here. I promise you, the problems they have are the problems you're going to have too. We don't know what those problems are in the beginning, but they do always pop up in these projects. And that's why we need a contingency budget, because of if we miss our date, if we need more resources, our testing's not going good, and we need to do things different, we may have to draw on more money in the budget. We don't want to, but I bet you'd rather have a contingency than me coming to you and telling you you need $2 million more out of the blue. That's going to be a change for you that's going to change the whole paradigm of the project and part of the organizational operations if that's the ask going forward. So training is another place that a lot of organizations take shortcuts on, specifically with physicians. It's their time, and they don't want to be trained. But this is a change, and as humans, adult humans, it's really hard for us to deal with change. I don't know if anybody's tried to learn a foreign language as an adult, but it's really difficult, and it's because we have so much more data in our head dealing with the language we're used to. If you want people to use the system going forward, they need to have the right role-based training for them to understand how their job is going to be different going forward. And this really is for all users. And Matt, I know you're not my CMO, but we got to get the CMO here at the table, or whoever's the chief medical officer in charge of the doctors, because they have to do training. If they don't, The rest of the system isn't going to work. I also need your team to do their training. I heard that the payroll manager didn't do her training. I'm concerned. Are we going to be able to make payroll? That's important to me personally, as well as the rest of the organization. So I need you to make sure the payroll manager does her training. Everybody does their training along the way. And that we have, if there are gaps that we see in the training with the software, we document those. Maybe we fix those. Maybe they go into an optimization phase, which would typically we would recommend going forward. And then go live. So, and by the way, talking about AI earlier, all these quotes that are on here, all I did was go to ChatGPT and said, I need a quote about X, Y, and Z. And it came back with so many options, it was amazing. So I do recommend using AI on anything like this kind of stuff, presentations, but also, as Jeff talked about earlier, it's just not done when you get to go live. Go live is just a milestone. It's a date that we picked, and now we're switching over to the new system. We've got lots of work to do. Our plan shouldn't end on 30 days after go live. Our plan should just be in a different phase, 30 days after go live. And you should treat go live as about a 30-day event, and then you should move into stabilization and those kind of things that we'll show in a second.
It didn't go well. Now what?
What didn't go well?
Just any of it. I mean, go live was very poor. So what are my options now for prioritizing how to fix things?
Part of our plan that we put together was that we're going to have an issues list. We're going to matrix that out. We're going to fix the things that are priorities that the team decides and the governance reinforces, and we're going to work through that. I talked to somebody earlier today, and I was telling him I was going to do this presentation, and he said, oh, I've heard all EHR go-lives are horrible. And I said, well, what does horrible mean? Well, just hard, difficult. Well, yeah, it's change. So it is going to be difficult. It is going to be different. Day 1 is going to be worse than day 5. Day 5 is going to be worse than day 25 for everybody in the organization. And so getting used to that, getting ready to support the organization through this change. One of the things I've seen organizations do really well during go live is have Matt or have the CEO come down to the quote-unquote command center, where all the data is coming in, and just cheer everybody up. Tell them, great job. I really appreciate how you're doing this. I'm seeing good things out there in the organization with this new EHR. I'm hearing good things from the patient accounting department or from patient access. Because that team, all they're hearing is how bad it is. All they're getting is all the issues that are coming in and how horrible it is. And so their morale is going to really valley out pretty soon. And they're going to get tired. They're going to get frustrated. That's a whole other part of our Go Live team is we're going to have a plan where not everybody is there when we turn on the system. So that's another thing. People make mistakes. Everybody wants to be there the day we change the switch. Unnecessary. We got to schedule out, just like we would schedule out for anything, people to have time off, time to rest, time to come back and be recharged. We can't have people working 20-hour days for 1 week straight, which is the kind of things that sometimes happen when we get caught up in critical issues and those kind of things. The other thing I mentioned earlier was the big bang approach, which often is unavoidable. But if it is avoidable, this is a great time to split the work up some so that Go Live doesn't have quite the same impact on necessarily the clinics or the acute side, or maybe your ERP versus your EHR. If your ERP is staying static and you can go live 6 months later on that, that's a good choice to make. Breaking this work down as much as you can is one of the best things that can make it easier. And then as you make changes, and this is critical, happens in testing, but it also happens at Go Live, we have to have control over that. We have to document those changes. We have to know who made them. We have to know why we made them in case they cause another problem. Because often when you change one thing in the system, you're creating a problem somewhere else. You just don't know it yet. It's going to come up in the billing cycle or something like that. So we need to be careful about how we make changes and work through that. And then obviously we need 24/7 on the clinical side going forward, but we don't need the revenue cycle team getting all worked up on day 1. There's not a lot they're going to be doing until we start to push data through there and claims through there. They need to stay working on the other system and get that cleaned up.
Yeah, it certainly seems that no matter what the problem is, no matter where it is in the system, it will wash into billing eventually.
stuff rolls downhill, I heard one time.
Yeah.
I don't know exactly if that's the right term, but yeah, I worked in revenue cycle for years, and I don't know how many times it was, the CDM was kind of the river you cross over from clinical to financial, and if the CDM wasn't set up correctly, things weren't going to come there. If people weren't dropping the right charges at the right time, revenue cycle is going to be messed up, and those kind of things. It's only gotten more complicated. I'm not a revenue cycle expert anymore, but you are, and your team is, and so I'm going to need you guys to tell me when things aren't right for what you see going forward. And that's during stabilization is where we'll see this. So, we're going to analyze where we're at. We're going to talk to the governance group about the successes we're having, the failures we're having. We're going to go back and look at our project charter. Is this what we expected out of the system? Is this what our scope was? Are we meeting it? Or have we not met some things? We need to push those into an optimization phase. Earlier, I showed the optimization phase is usually about 6 months. And that's not going to be, things changed and we go out and see how they work in the system. We're going to come up with the change control. We're going to document that. We're going to go tell the department we're making a change so that they can know the change. We're going to train them on the change so that they understand it. And we're obviously going to test these things out really well before we get there. And the last place that we get to is normal operations. And this can seem like, this is an eternity, right? This is you and your vendor having a relationship. This is transitioning to steady state. Things are changing on their own now that I see that. When we bring new staff on, are we training them on the system? Do we have did we develop training before we went live for new staff? Or is that what the nurse informatics team is doing day 2 of go live, creating all the documentation for how they're going to onboard the next 3 nurses that come on or 30 nurses that come on in 2 weeks? And then ultimately, in the beginning, one of the challenges we had was around financial KPIs and analytics. And this is where we should be really investing in that so that the C-suite has what they're looking for and ultimately the board gets what they want, which is the analytical data, the KPIs, the dashboard that's going to help them move through managing the hospital. So, Matt, are these the things that we talked about in the beginning, like the unrealistic ROI expectations?
Yeah, I think what I've learned today is that there's almost no amount of planning that is too much for this. This is probably one of the single largest events that can happen to affect your operations. It touches absolutely everything, and importantly, everything that goes wrong is more money to fix.
That's 100% right, and no matter how much planning you put into this, there's going to be problems. I mentioned I went to my CFO and told him I needed some money in 2006, 2007, I can't remember. In 2009, we went live with that system. And much like this setting, I was about 45 days after go live, I was at one of the hospital retreats and taking a victory lap, and everybody was like, oh, this system's great. This is before meaningful use, so the systems weren't as complicated. This is great. And while I'm up there talking, my phone is vibrating in my pocket a whole lot, more than usual. And then I noticed a lot of people in the room, their phones start lighting up. And so director of pharmacy raised his hand, Jeff, I think you need to stop this conversation and head back to the hospital. And so I said, okay, what's going on? So we looked at it. What happened 45 days after our go live was the vendor went in and made a mistake and copied our test system over our live system. So what people were telling me was, this order set doesn't exist anymore. That pharmacy drug's not there. We can't do things. What happened? So we had the best intentions. We did everything we could. And some external, to me, person came in and pushed a button. And they didn't tell anybody either. That was the other thing. It took us 3 months to discover what had actually happened. Even the vendor couldn't figure out what had happened. But what we did, we had to come back and rebuild everything that we didn't do, right? And luckily we had a lot of documentation on that and those kind of things. So it's never over. You're always going to be optimizing. You're always going to be moving forward and trying to help with the system. But, hopefully, through the planning, you've documented what we need to do, like you talked about, Matt, and hopefully we're not going to damage the hospital too much. But this is one of the most disruptive actions we can take is to change the information system that the majority of the staff use, including the providers, the revenue cycle team, and those kind of things. So thanks. I know this was the last one. So luckily we went fast, and you guys can get to happy hour sooner. Are there any questions or comments or anything that you'd like to offer?
So I have a question specifically on the testing phase because I feel like that's an area that things can really go right or wrong. You kind of know where things are headed. One of the things that I know is a real challenge during that time is you have the vendor who has the expertise in the system, but then you have the people who are working from the company who know the business process, but they don't necessarily know the new system. And so you're not completely aligned across, both parties. And so with that, when you're trying to ask the people who work for the company, hey, we need your input on this, it's kind of hard to know how to do that because you don't know what the system's like, and your business processes are most likely going to change when you move to the system. So how do you kind of align that during the testing to kind of figure out, hey, we know or we don't know what we don't know, and be able to do something.
Right. So different phases of testing to begin with, right? So basic testing would be unit level testing, which your builder or your person who's setting the system up should be doing. I press this button and this happens, and I expect that to happen. What we're talking about when we get other people involved is really what I call a parallel or more of a mock live testing. And to do that, we have to train. So that again starts to show if our training materials are effective. So we're going to invest in other people and other time, and that's going to pay off, right? When we go live, they're going to know more than other people. So these might be your super users on the floor in departments and things like that do this type of testing. But it's an investment. It's part of our plan. Our plan said we were going to take different people. We were going to backfill them also for 1 week, 2 weeks, whatever it takes, and we're going to train them and let them use the system. And the vendor should be there in these times completely to be involved, but the vendors is not the one who says it worked or it didn't work. It absolutely is the governance group who should be voicing, we agreed with the testing, we're okay with it, we know what's going to work, we know it's not going to work, and we're prepared to either work around that or resolve that as soon as possible as we go live.
I'd say from my perspective, if during testing and during the setup phase, you're discovering that your people only speak operations and the vendor only speaks software, then you shouldn't be afraid to hire a translator. We use Tegria because we got to a point where we realized that, it was a situation where they would ask us, well, do you want this radial button pushed or not? And we would say, okay, so what happens if we push that radial button? And they'll say, well, it does this. Okay, well, what does that mean for operations? We don't know. Do you want it pushed or not? So it's one thing to have someone who, can understand both sides of it well enough to say, this is what's going to happen if we push this radial button, not only in this module, but then 3, down from there.
Integration, right? And that's another piece, especially if you're bringing together acute and ambulatory during an implementation. Integration is going to be the word you're going to hear from your vendors, how great it is. And it is great. But it also has implications. If you do something over here, downstream, it's going to have an effect. If you change something in pharmacy, it might affect the ambulatory clinic, where before it didn't. And now you need to be prepared to support that going forward.
I was just going to say that, we've gone through so many implementations, based on our regions and so forth, that what we found was updating our workflows, because workflows can be outdated, right? And during that implementation opportunity, having that discussion with your partner, right, as you go through this implementation migration, having that revisit of workflows and justifying, is this correct and how does it flow within the system? It's checks and balances. So that documentation has been really essential and been successful to our implementations and our go-lives.
Yeah, and ultimately, when you think about the go live work for what sometimes we call future state, well, that's your training materials now. You've just created a draft on the workflow you're gonna train on the people that come into those departments. So there's value in those, not just in the project, but in going forward. But yeah, and it's a time to improve. You should never take something like this and say, well, we're just going to continue to make use of an inefficient process and just automate it. Let's make it better. Let's see what the technology will do, and those kind of things is really helpful.
You talked about some of that process work, and if we've learned any lessons from other enterprise systems, implementing a new enterprise anything is a great time for process change and process standardization. You talked about this big bang versus small. I mean, you start in oncology and everybody gets what oncology decided to do. Might not be everybody's favorite in the end. So doing that process work up front, how does that play into the planning?
So when I talk about separating the go live, they're still involved in every decision. It's just that their go live date is different. It's delayed or pushed back some time so that we can take advantage from an operational standpoint of that side of the hospital. Usually, and to be honest, this is almost always ambulatory that you delay, because you're typically, maybe you're on ECW or Greenway or Athena over there, and you're moving to Epic Connect, or you're moving to Meditech or something like that. You can maintain that separation. Your vendor is not going to like this at all. They're going to hate this idea, because that means they have to support 2 go lives. And your vendors are typically going to build into their contract support for 1, and that's what they're going to sign up for. So you need to, again, during planning, you need to be thinking about these things and planning them out. But you are right, whoever goes live first can't own all the decisions. We can't just start doing things the way the ED docs want because they went live first. We need to make sure that the primary care physicians and the specialists are involved in any decisions. And we should have along with a governance structure for our C-suite, we should have a physician governance structure too, where we take these kind of things to them and they approve them and they buy into them.
I think we talked a little bit about making sure that the CMO is involved in the testing in that phase. And to me, getting the providers to the table is one of the hardest things. I think, we've all shared that kind of experience. Getting providers to do anything they don't want to do is very difficult. But now is the time to preach fire and brimstone. Now is the time to tell them what is going to happen if they do not train on this system, and that we're going live with it at some point. They will need to learn. They should do the work up front.
Yeah, completely. You want physician buy-in early, like I mentioned in the training one. They need to be part of the process. Some of the pictures I forgot to say. A lot of those in my eyes are the times like you're building something, an order set, as an example, for pneumonia or something. Well, that's the time to have a provider come by and see that and see, oh, that's what that's going to look like. And so they start to visually understand what the system first looks like, then how they'll use it. These are some of the obstacles that you really face is they have, like you say the word Meditech. A lot of organizations will think of that black screen with green writing on it, the magic system that used to exist, especially doctors. Oh, that's what we're doing? Oh, that's horrible. I can't do that at all. The versions have changed. You want to make sure they understand what they have, what you're going live with, and they see the system and can see themselves being successful in it.
So one idea that occurs to me is to get physician buy-in is let them know this is going to be a practice management tool for them, that if they give you the right requirements, they can get the right outputs later to help them standardize care across their different docs to control their practice. So if you build in wins, they're more likely to participate in the project willingly.
Exactly right. That's exactly right.
Maybe a combination.
Well, you need a carrot and you probably need a whip too, right? So there's stick, right? You got to have both. one of the things I've done in the past is, celebrate physicians who are successful using the system, show some KPIs or something, and then have a list of those that aren't, and put that up on the wall somewhere, and use peer pressure. Physicians of all people are very competitive, and so the last thing they want to see is they're the last on documentation, or they haven't done their training and those kind of things. So use social engineering to help push the project forward with those stakeholders who can be challenging and require a little nuanced control or manipulation, however you want to call it, or bring in the hammer. Bring in the people who said this is how it's going to be. Thank you so much for your time, and we're 13 minutes early, so you guys are going to get to the bar earlier apparently.